Demographic Health Survey, or KDHS 2022, revealed that 80% of children in Kenya are fully vaccinated for basic antigens. However, the target for this should be 90%. Now, a brief snapshot of the county coverage shows us how they are faring. When you take a look at the top 10 counties with the highest percentage of children between 12 and 23 months that are fully vaccinated, from Vihiga to Murang'a, Tharaka Nithi, Nyandarua, Nakuru, Kakamega, Embu, Nandi, Uasin Gishu, and Kisii, all registering over 90%. Kwale County, Isiolo, Marsabit, Samburu, Kajiado, Turkana, Wajir, West Pokot, Mandera, and Garissa, all registering low percentages. Garissa with 23%, but that's exactly what we're talking about. This year's theme speaks to the big catch-up. And so key stakeholders, including the Kenya Pediatric Research Consortium, through the Championing Evidence-Based Advocacy Project, are having critical conversations around immunization this week. And this one happening right here on Citizen TV with the County First Ladies Association, who are advocating to improve the coverage of immunization in their respective counties. Now, allow me to introduce my distinguished panel. To my immediate right is Dr. Nelly Bosire, and Championing Evidence-Based Advocate Project Senior Technical Advisor. Thank you so much for joining us. We also have Her Excellency Anita Mutula, Makueni County First Lady. Thank you for joining us. We also have Her Excellency Agnes Ochilo, Migori County First Lady. You've been here before, so welcome back.
Thank you.
And we also have Her Excellency Lilian Kamudei, the Turkana County First Lady. Thank you so much. Let's begin, Dr. Nelly, with looking at what has been done right so far. We've just looked at the counties that have registered over 90% coverage. What do they manage to do to get to that level?
Well, it's been a struggle, and it is not just for the counties. We have to appreciate that the KDHS, looking at children 12 to 23 months, is actually talking about the immunization status of what has happened during the COVID period, which is 2020 to 2021. Now, this has been a very difficult time. Health systems were hard hit. It's not just a Kenyan challenge. It is actually a worldwide challenge. There are countries that saw great dips that we say we haven't seen since as far back as 2008. So we're actually talking about when we look at what the KDHS has given us, it has actually talked about how resilient is the system in your country. And to be able to have counties doing as wonderful as Vihiga hitting 96%, it really does speak to resilience and make us look at us as a country and say, beyond COVID, what other challenges have we been able to address effectively to actually reduce the issues that we have. So one of the things that we know right now is that the immunization program is a national program, and it is really run primarily from Afya House. However, they will avail vaccines, but the county now at ground level then must step up and ensure that these vaccines have actually reached their own population. And so what have we done right? How close have we brought service to the people? How well are people able to make it to the vaccination centers? And if you actually look at the counties that are leading, the one thing they have in common is that heavily populous counties. So people live within the vicinity of their health services. They will be within 5-kilometer radius of their health center or dispensary or county referral hospital where the child will get vaccinated. And if you look at what's happening on the other side, it becomes the exact opposite. So in terms of access, in terms of communication, we have strived very hard to look at what we can do with primary health care, and this means bringing in our community health volunteers. Again, Vihiga County, one of the few that has actually facilitated its CHVs to actually do their work. And you'll be surprised, in places like this, the community health volunteer knows every child born within the radius that they serve. And so they're able to ensure that all these children are making it to the vaccination centers. They're able to make sure that they are getting the service that is required. Particularly, Vihiga County has actually the Mama Care program, which is the Otichilo program. And one of the things they did is that every visit a mother makes to the clinic, she's actually paid 2,000 shillings. And this has been such a great motivation that all moms who are pregnant will actually attend antenatal clinic, that when they come for postnatal care, that becomes an opportunity to make sure the baby is seen. And with every subsequent visit for the first year of life as the child is coming to get their vaccines, they still get facilitated to make sure that not having transport is not your excuse not to bring the baby to the clinic. And we can see what that has actually done.
You've talked about incentives, you've talked about CHVs, knowing the babies that they deliver at a personal level. That makes a huge difference.
Absolutely.
Madam Lillian, let me come to you, because Turkana, of course, has struggled in terms of coverage. What are some of the challenges that you'd say have affected your county?
Okay. Asante. Mi naitwa Lillian Kamria Kamais, First Lady, Turkana County. Actually, county yetu ya Turkana inaathiriwa na mambo mengi ya magonjwa, na aswa kabisa mimi ni ambassador ya wale watu wameathiriwa na ugonjwa ya kansa. Hiyo ndo nimejitokeza nikiwa First Lady Turkana County, na natembea katika vijiji azua kama magonjwa haya ambaye sasa hivi leo ni wakati wetu wa mambo ya chanjo ya watoto. Wakazi wetu wa Turkana, kuna wale ambaye waishi karibu na town, wako distance mbali na town, na hivi tuko na hospitali yetu ya county. Kitambo mama achukue nafasi ya kutaka kuleta mtoto kwa matibabu kupata hizo madawa, inachukua muda kwa sababu anatoka mbali sana. So pia inategemea na mambo ya fedha. Wenda ikawa hana fedha ya kuweza kumfikisha pale hospitali, na tunajaribu kucapture mahospitali zetu ndogo ndogo ambazo zinapatikana huko ushago, ndio hawa wale wamama waweze kufika kupeleka watoto wao kupata chanjo. Na wenda ikawa akifika mahali pale pengine mambo ya matibabu, nafika hospitali anaambiwa enda chukua dawa, kufika mahali pale hakuna dawa, aende arudi. So hiyo yote inagharimu na mambo na fedha. So inafika mahali mtu ana lose hope kusema sasa ya nini, kwa sababu sina hata fedha ya kwenda kupeleka mtoto apate hiyo chanjo. So tulikuwa tuna prefer ya kuwa tuna ile tunasema kaunti yetu ya Turkana tuweze kusaidia na tupate madaktari kwa wingi, wale wanaweza kuwa vijijini mahali pale, na pia tuko na madaktari ambao ni wa vijiji. Kuna wale madokta, lakini kuna wale madaktari wa vijiji ambao natakana wapeleke injili kwa wale wamama wako pale msituni, kuelimisha, kupeana mafundisho kwa wale wazazi, wawe na ile uhakikizo wa kuwa watoto hao wanatakana waletwe wapate hiyo vaccine, kaswa kama ya polio, sio kama ya hiyo tetanus, hiyo sana sana unaona kama kuna shindano hii ya miezi 9. Kuna watoto, baadhi ya watoto hao wapati hizo dawa. Kwa sababu gani? Huko ushago, wakati mtu anaona mtoto wake hako healthy, hana shida yoyote, sasa anaona ya nini niende nipate hiyo dawa. Lakini magonjwa hayo inapatikana kwa sababu ya ile kupuuza mtoto akose kupata hiyo dawa ya vaccine ya pengine ya polio ama ya measles. So hayo ndio iko katika kaunti yetu ya Turkana. Kama mimi First Lady Turkana nilikuwa naomba hivi, serikali yetu iweze kutuongezea madaktari kwa wingi katika sehemu yetu ya Turkana, na ndipoza wapatikane katika zile dispensary zile ndogo ndogo ziko kwa vijiji. Alafu kwa wale madaktari waweze kuwapata wale wadaktari wa vijiji kupeana neno hili iweze kufikia wamama wale uko milimani ambaye sio rahisi wafike mali hapa. I think in high nitakuja kuzungumza baadaye.
No, and thank you for sharing that, Madam Lillian. She talks about this need for having more doctors out, especially in the villages. That coverage is necessary just to keep tabs. Let me come to you, Madam Agnes, and what's happening in Migori County. Do you find the same issue, money, access, still plaguing some of your constituents?
Thank you, Victoria. In Migori, actually, I thought you were doing very well because our KDHS figures are about 83%. But now it has been brought to my attention that actually those are just the basic vaccines. We should be having the national schedules, which now place us at 73%. So it means out of 10 children, I have 3 who will maybe face challenges due to immunization. The way I look at it, we have challenges on 2 fronts. We have challenges when it comes to the demand, and we have challenges when it comes to the supply of the commodities. You find the demand, some of our people, just as my colleague has said, don't know the benefits of immunization. For them, once the child is okay and they've gone through the process, they feel that is sufficient enough. Then secondly, they also don't have access to make them reach where they're supposed to be going. Like, you know, in Kenya, because of the economic situations, nowadays we have what we are popularly calling side hustle. So you want to choose, do I go walk a long distance to go to the hospital, or do I stay home and take care of my children? In my country, we have a lot of gold mining. Do I go to the gold mines? Do I go to look after my omena by the lake to dry, or do I go to the hospital? So they don't see the need. If the child is not sick, they don't see the need. And then now when I look at the supply side, we've been having a lot of erratic supplies of the commodities. You find a lady will walk all the way. There are quite some distances. So you reach there, you're told, hazijakuja leo. So you go back again. And then we also have the challenges of even the fridges that keep those commodities. I was talking to our people yesterday, and they told me that out of the 200 facilities that are supposed to be providing the immunization, 42 of them don't have fridges. So that means that those vaccines cannot be kept there. So it means if there's a lady around there who needs to go there, then they'll have to get other ways of going there. And then also you find that there's competing demand for the service providers. There's competing demand in terms of what they can acquire and keep, and there's competing demand on what they can do, because because as Turkana we are also understaffed, and you'll find that you'll be faced with the question: do you attend to this person who's come who is already sick, or are we going to have the providers concentrate on the children or the vaccination process that is not health threatening at that point? So those are some of the challenges. But I must say that because of the Linda Mama program and the Beyond Zero, they created a lot of demand, because you find that most of the rates, the vaccines that are highly taken are the ones that are taken just before you get the baby and after you get the baby. Because before you get the baby, you'll go to the facility because you want to register for Linda Mama. So because of Linda Mama, you go there, and in the process you get these other vaccinations, and immediately the baby is born, because you are still within the hospital vicinity or in the wards, you are able to get the vaccinations for the children. But after that, you go home and there's no motivation to go back. I'm glad Vihaga, they are paying the mothers. I think I'll go and talk to my husband and find out what they can do about that, because the benefits of immunization are so high that we don't want to lose even one child because of lack of vaccination.
Let me come to you, Madam Anita, in Makueni. Do you find that it could be an issue of people not seeing the seriousness or the need for vaccines that's holding them back, or access? What are some of the challenges in your county?
Thank you, Victoria, and thank you for having us. What I would say for Makueni is that so far the uptake of the immunization has been almost at a very good percentage, because we are at 82%, and considering the national percentage of being 90, as in that is where we are supposed, that is the targeted percentage. So I must say we are doing well. So far the uptake has been good. The sensitization, especially to the mothers, is where I think we face a challenge at most, because you find them, illiterate mothers do not find the need to go back after especially the delivery to go and get their babies immunized. So then I think that is where we need to operationalize a lot and encourage these mothers to go back for their postnatal clinics and get their babies vaccinated. But I must say that immunization generally plays a key role, especially in adulthood. And donors and government have been very supportive matters immunization. In terms of the supply and containing of the product in our county, I think as Makueni, we are not complaining. We are not complaining. So far, so good. It is just now to maintain what has been happening and continue with the same theme.
Certainly, I'll come to each of you to ask, what special advocacy tool you'd want to use, especially when it comes to this immunization campaign. But let me come back to you, Dr. Nelly, and look at what we're calling the newest kid on the block, HPV. And you've seen experts really get concerned about uptake. It's quite low. We saw the ministry talk about opening it up to primary school boys in February. But what are we doing about that particular vaccine?
Wow, I think HPV is the one that just totally got the short end of the stick here. First of all, HPV target age is about 9 to 14 years. Okay. So every country has to kind of tailor that to what works for them. And in Kenya, when we first launched the HPV vaccine, we actually opened it up to 10-year-old girls. And after a few months, we realized that they're going to expire in our facilities. So we have been expanding that bracket, and now we're actually looking at 10 to 14-year-olds getting vaccinated. Now, with HPV, one of the biggest challenges we actually suffered was that we launched HPV, and less than a year later, we went into COVID. Now, HPV is given to kids who are in school. And that has been one of our biggest catchment area to get them vaccinated. So we sent them home for a whole year because the entire 2020 children didn't go to school. And the program literally stopped because children are not in school. Attendance to facilities is only for emergencies because our systems are overwhelmed with COVID-19. So we are literally back to the drawing board, and what we have done through 2021, 2022 is almost a relaunch. Okay. Because there is nothing to pick up from. And I have to commend the Ministry of Health that they've done a lot. However, we're still struggling with information and HPV. And first of all, adolescents are usually the most neglected group when it comes to healthcare. An adolescent child is big, they are grown. If they have a headache, they will tell you, Mom, I have a headache. And then you can take care of the headache. So if they don't have complaints about their health, unlike a child who's below 5, we are not going to be checking. We wait for them to complain. And that means that without noticing, when it comes to their health, attention from the caregivers gradually slips. So when we actually want to target them for medical interventions, we are asking parents to wake up to the realization that there is this set of children you also have in your house we need to pay attention to. And then we say, let's vaccinate them in schools, but then it means that we need parental consent. So when you bring your child to the facility for vaccination, you have already implied consent. However, when they are in school, I am asking a teacher who has 100 children in their class to start writing slips for consent, to send home with the children, to bring them signed. Then now we can say, yes, we shall vaccinate this child. No, we shall not vaccinate this child. Some of these children, their parents have never even seen the slip. They do not know what is going on. So the efforts are going to be twice as hard as for those who were giving vaccination in infancy. And so we then are at a space where we say, for us to be successful, what is going to go into health education and awareness is a lot. We are really going to reconfigure how do we deal with the issue of consent in schools so that we continuously target these children. We are going to look at using other avenues. They're home, schools are closed. Can we meet them in churches? Can we meet them in areas where they are coming together with their parents? And see if we can use those opportunities to vaccinate them. So it is one that we know programmatically we have to really keep rethinking, re-innovating around this to make sure that we get our target population. And we also, over the long run, hope that we can change the mindsets of parents on how they view their adolescent children in view of preventive medicine, so that they don't only need to take them to healthcare facilities for treatment when they're sick, but also for preventive care. And that means then we really have no choice. We totally must build our primary healthcare systems to work. The CHVs have done a lot of work in terms of sensitization. It has faced a lot of challenges in terms of misinformation. So it has been a work in progress to try and, to undo the misinformation and build what our First Lady Anita here talked about. We must build that, demand for it. Yeah. And when we build enough demand, then I think finally we can gain the momentum that is required.
Speaking about momentum, you're just beginning with this campaign. Immunization Week is kicking off, and we have 3 fantastic First Ladies here who are holding the torch in each of their counties.
Absolutely.
Madam Lillian, what is success for you in your county? What would that look like?
Actually, Madam Victoria, Turkana ina changamoto kubwa sana. Changamoto ambayo inaathiriwa hata na bandits wale wanatuumiza, kwa sababu nimewazungumza juu ya umbali. Actually, mimi nilikuwa naomba kabisa kama kuna njia yote ambayo mnaweza kutufikia Turkana kwetu, muweze kutusaidia. Naongea kwa sababu ya juu ya serikali, sababu ni serikali ndio wasaidizi kupitia kwa makampuni. Vile wanaweza kutusaidia kwa njia moja wala nyingine, ili tuweze kusaidia watu wetu. Tuweze kusaidia watu wetu wale wako pale msituni. Unajua, sana sana kuna baadhi ya wazazi ambayo wanaona hii madawa ambayo serikali anasema mpeane kwa watoto. Wengineo wanafikiria pengine madawa itakuja kudhuru afya ya watoto wao kwa njia pengine ya uzazi. Unaona, hata wakati tunapeana hizo funzo, kuna wengine sio wote wanaweza kupokea. Kuna wengine wanakana kusema hii dawa mtoto wangu hawezi pata kwa sababu itakuja kudhuru kwa wakati wa uzazi, pengine mtoto wangu atafika kiwango fulani aoleke na italeta shida kutokosa kupata mimba. So ndio nilikuwa naomba kuwa tunahitaji madaktari. Na madaktari hao tufikie katika Turkana, kaunti yetu ya Turkana, ndipoza watoke waende nje kuelimisha wamama hawa kila wakati. Waingie kwa line, waridhike na ile hali vile inahitajika kufanywa. Azini kama mimi naweza peleka hiyo ujumbe. Na pengine changamoto wakazi wetu wa Turkana, ama pengine kuna sehemu naweza tembea na kuna sehemu siwezi kutembea. Lakini nilikuwa naomba eliminate wale wa madaktari wa vijiji na kujenga pia hizi madispensary kwa wingi Turkana mzima, ndio iweze kufikia wale watu wajiwezi pengine na mambo ya fedha. Ile kitu changamoto nyingine kabisa ni mambo ya fedha. Wakati mzazi anakuja pengine ameambiwa leo dawa haijafika, anarudi, dawa haijafika, anarudi. So ana lose hope. So long as mtoto wangu ako na afya, ni nini naweza shughulika tena? Unaona, wakati sasa mtoto ataanza kugonjeka ndio ataanza kurealize, nataka nipeleke mtoto wapi? Hospitali. Kitambo ufikishe mtoto hospitali amepatikana nayo magonjwa. Kwa sababu gani? Hajapatwa na zile vaccine, anataka na apate hizo chanjo. I think unanipata vile. Na umbali huu na hii mambo ya bandits, pengine watu wanaishi mbali. Mama anafikiria akitoka ni mangapi atapata naye barabarani. So hiyo kitu imefanya watu wetu wengine wanakataa kwenda kupata hii mambo ya serikali nasema pelekeni watoto kwa chanjo, fanyeni hivi, wanakuwa na ile uoga. Pengine hospitali iko hiyo dispensary ama hospitali iko kilomita karibu 52 kilometers. Na hana pesa kupanda gari ama hana nauli ya kupata pikipiki kufika mahali pale, so mtu anaendelea kukaa. So ni ombi langu kwa serikali na pia kwa kaunti yetu ya Turkana, kwa sababu pesa inatoka serikali iende kaunti, ndio kaunti ifikirie kufanya vile watu wetu wanaweza kusaidika.
You know, Madam Lillian has raised a huge issue that is not just unique to Turkana, it's pretty much the North Rift that has been affected by insecurity. And we really underestimate how much of a factor that is. Madam Agnes, in Migori, you talked about people having split interests. They want to do their side hustle, but you also have to take the child to hospital. And it was interesting to hear you say you're really inspired by what happened in Vihiga. And you hold a lot of influence in your county. How do you want to use that to kind of see a change and a shift?
Yeah, as I had mentioned earlier, I want to look at it from two angles.
Yeah.
Because I don't want a situation where mothers know the benefits of immunization and then they go to the facilities and then they find there's no vaccine. What I want to focus on, number one, is to ensure that we create awareness and knowledge, the benefits of the vaccine. We tell the mother that if they want their child to be bright in future, they should at least ensure that they get those vaccinations, because Nelly here has taught me that the child's brain develops in the first 3 years. If you make a mistake within the first 3 years, then you might have as well give up on the child. Not really give up, but the potential of the child will be lowered. So I want to educate the women so that it becomes part and parcel of their life. They know that once they conceive, they start the immunization process immediately. And then on the supply side, what I need to do is to ensure that we have more or less a multi-sectoral approach, because some of the hindrances to vaccination even come from the religious community. Are we going to tell the religious clergy that vaccination, I want a woman to go and have the child vaccinated, and then the next day come to the house, to the community and fit well? They don't feel like they have done something wrong. So I need to create awareness right from the barazas, where we have everybody, and even the provincial administration. I've realized that even the provincial administration is very, very critical, because you know, they'll say what they're saying, and if you don't follow it, they might even penalize you for that. So I'm looking at a multi-sectoral approach where the recipients, the women, the children, realize the importance of this vaccination, so that they know if the benefits of having that vaccination done. The religious community also appreciates, like we've had a lot of challenges with the HPV, where parents or some people have been made to believe that if your child gets the HPV vaccine, then they might as well be barren. It is a pointer that it makes them barren. So what we need to do is to ensure that these people understand. And one of the ways that we've done is we ensure that our own relatives, unfortunately I don't have a girl who is 10 to 14 years, but I've encouraged my sisters to take their children. My sisters' children are vaccinated, and I'm able to tell them and relate to them, tell them, if this one has gone, does it mean that I would have exposed my niece or my grandchild to a vaccination that will harm them in the future? Because people normally believe they appreciate when they see it happening in real life. And we are also encouraging the government to ensure that, of course now this is the county government, to ensure that those commodities are available within the facilities, because we don't want to create excessive demand, because we have very strong CHVs on the ground who are able to get these women to go to hospital, but we don't want them to go and then they reach there and then they find there is nothing. And also, I'm also encouraging, we were speaking with the health team of Migori, and we've realized that at times it is better to take these vaccines to where they are. Is it possible for maybe 3 health providers to avail themselves on a market day? Go to the market, because women always come with their small children to the market, and at that point they are able to get the children vaccinated and also be informed of the pending vaccines that they need to go for. Are we able to go to the mines? Where, because even there, the women have to go with their children. You can't leave your child at home when you're going to stay at the mine from morning to evening, because you have to breastfeed and you have to do everything. So are they able to go to the mines? And then are they able to go to the shores of the lake? You know, when one of the activities that the women take a lot of their time tending to is drying the fish. You know, you have to be there physically, because if you're not there, the vultures will come and eat all your fish. So, and there, you know, that's something they can do with their children. They'll even carry for them food and feed them. Are these people able to go to such areas so that if the woman cannot make it to the hospital, are we able to go an extra mile to ensure that we reach them where they are? Because I want us to get 100%, because there's no need. I'm not happy with even the 90% that they're talking about, because no child should be left behind. Maybe the one we are leaving, the one will be our future president. So we should have 100% vaccination for all of them, and that will be my joy.
You know, it's amazing hearing from all of you, because you're on the ground, you interact with the people. You've described different scenarios. Madam Lillian talking about the insecurity, the distance. You're talking about, you know, fishermen and miners and, you know, women in the market. So it's not always going to be a case of being in a built-up area. You go to the hospital. That's not everyone's reality. You know, let me come to you, Madam Anita. When you look at Makueni and what approaches could work when it comes to reaching your constituents?
Okay. In Makueni, I'd say, considering it's the nurses that conduct the immunization process, I'd encourage maybe we empower more CHVs to be able to do this. And also the CHVs could also be encouraged to sensitize the mothers also to understand the need for the uptake of the immunization. You have also discussed the issue of the HPV. In a country like Rwanda, we are doing 98% matters uptake of the HPV vaccine for both boys and girls. I'd want to see a scenario where it's we are having the same situation here in our country, because we've been focusing a lot on the girls, and now we are doing also the boy has also now come into play, where they're now also being introduced to the HPV vaccine to reduce the cancer infections. Now again, also for the uptake of the immunization in our county, apart from staffing, I'd also say the sensitization. The sensitization where I'd like to see a scenario where we have, in the digital world, messaging is reaching out to the women in the last mile to also be able to see the message and understand that if the data was collected that a certain mother delivered between this period and this period, they can receive the message and come and do their vaccine. I think then that way we'll be able to reach more numbers, because you realize once they are discharged from hospital, most of them take a longer time to come and do the vaccination, because most of it, like the BCG, is done at birth, but some of it is required that you come and do after like 6 months or 1 year. So it would be good, even in the data collection, to understand who delivered at what point and what point they need to get administered for a certain vaccine. And that also now calls for also the CHVs to be able to be empowered to also collect actual data of those mothers that are delivering. I think then in such a scenario, we will see more uptake of the immunization. Otherwise, so far as of Makueni County, we are at 82%, and we aim for the 90 to 100% of the uptake of the immunization.
Fantastic. And I mean, those are all percentages we'll be tracking as well. We'll be cheering you on as you strive towards that. But Dr. Nelly, yes, go ahead.
Something just came to my mind.
Yeah.
You know, I recently had a fistula camp, and something that really worked for me is when Safaricom sent messages to everybody within the county. So I think we should also pursue a lot of digitization, because I've realized even the the poorest person in the village has a phone. Yeah, that's what in fact, we are servicing our phones more than even other items. So if we can have a situation whereby we are able to track these mothers, I think from the time they conceive, or the first time, or any time that they visit the hospital, or even we can pick data as they get married, because people get married, and we know that after they get married, the next thing is to have children. So some of these communication companies like Safaricom, Airtel, and the rest, they can come together, maybe do something with the county so that we have these people tracked throughout, because I know anytime a message comes to your phone, you look at it and you'll act on it. So maybe digitization is one area that should be looked at in detail so that we are able to keep track of these people.
I wonder, Dr. Nelly, how we can... Yes, Madam Lillian, something to share, please.
Asante sana, Madam Agnes. Unajua, katika pengine sehemu yetu ya Turkana, ziwa kama umeangalia mambo ya Safaricom, yes, wote wanaweza kuwa na masimu, lakini sio wote wanaweza soma kile kimeingia ndani ya simu. Ni message gani imeingia ndani ya simu? Kama uko ushago, hata Kenya sio wote wamesoma, but mtu anaweza kuokoa tu na simu, lakini message inaweza ingia kwa simu na ujui nini, mpaka upelekea tena pengine kama mtoto wako amesoma, unisomee kuna kitu pengine kwake atafikiri pengine kuna mtu amemtumia pesa na kumbe ni message ya Safaricom. So ni ngumu. Hiyo ni kwa upande ya Agnes, lakini mimi personally nikiwa Lilian kutoka Turkana. Na si vile watu wa daktari kufikia watu, hata kama kutakuwa na hiyo wakati, wachukue hiyo wakati wa kutembelea mpaka vijijini, mpaka huko milimani. Kuna watu wafiki town, kuna baadhi ya watu wako town wanajua umuhimu ya hii dawa ya vaccine, lakini huko ushago hakuna mtu anajua. Lazima nimeongelea mambo ya bandits na mambo transportation, hiyo inaleta issue. Na nilikuwa naimiza serikali kwa waajiriwa kama Chase and Peace, wale madaktari wa vijiji. Unajua wakati watu wanapewa allowance, ndio unaona mtu anakubali kuwa na ile willing ya kufanya kazi. Lakini kama hakuna allowance, anaona tu ni napoteza wakati wangu bure kwenda kutafutia nini watoto wangu. So nilikuwa na makaunti wajaribu kusaidia wale madaktari wa vijiji vile watabustiwa, at least wawe na ile umoto wa kufanya kazi kufikia wale wamama wako nje, at least wapeane funzo ndio walete watoto kwa chanjo.
She mentioned something very important, money, financing. You can't do a lot of this without
money.
You know, so Dr. Nelly, you mentioned this is mainly a national level operation. Have we reached a point where we can say we have properly funded our immunization programs in the country?
So we have had the international perspective to immunization. And I think if there was anything that could have taught us, we saw what happened with COVID-19. One person not vaccinated in Kenya will have an impact on the person in India or the person in Brazil. That is how challenging disease control is. And it is with that respect that decisions about vaccination are not even just at national level. Okay, we have had Gavi, the Global Vaccine Initiative, that has actually worked as one of the partners that tirelessly ensures that vaccines have been availed to everyone. And so what the program is now looking at is every country will be supported to provide vaccination. But as the country becomes more empowered economically, then we start to shift responsibility towards taking over full financing of vaccines for your country. With Kenya, immediately we were declared a lower middle income country. We now must be ready to take over. And we were supposed to have done this by 2022, but because of COVID, we have had to be given a bit more allowance to be able to do so. But the target now is that by 2030, Kenya must be self-sufficient in provision of vaccines. So we are on a race to make sure this is happening. There is a lot that's being put in place to ensure that we do this. We do not want a situation where when our donors pull out, then we go through 6 months to 1 year of hearing, our children do not have vaccines. So the same importance, and that's why for us we keep saying we encourage government. We are right here. We really want to make sure that we don't allow government to forget to be ready. We do not want a scenario where things go south. But we also must appreciate that the Kenyan program of expanded immunization has done an amazing job. There are many players who are looking. I know even the CS and the DG have actually made mention of this in several meetings, that yes, we have no choice. It's not optional. We must get ready. We must ensure that we are ready for vaccine programs once we have to fully take over. So this is going to be seen when we know, when the time comes. But meanwhile, I think the availing of the vaccine and the programs running smoothly, that yes, we have bought the vaccine. Is it reaching the people? Are we creating demand? Are we addressing the reasons why we have challenges with vaccination? Then we can be able to work with something. If you look at the counties that have been performing poorly, they are all having the same exact challenges. In fact, for them, COVID was not the problem. There wasn't much contact with the outside world and they were relatively protected. But what we're hearing from First Lady Lillian here, insecurity is a big deal. There is no way people are going to worry about where they are taking their babies, they will arrive safely. That while they're waiting on the queue, there shall not be stray bullets, that when they are done, they can get home safely, until if you actually look at the bottom 5 counties, they are plagued with insecurity. So insecurity is not optional. For us to be able to access immunization for all of our children, we must ensure security first. The second thing is access. Now, again, those bottom 5 countries, we have Garissa, we have Mandera, we have Wajir, we have Turkana. What do they have in common? They are huge counties with sparse populations. So to think about building a health center every 5 kilometers is not logical. So what then are we doing on logic? Where are our mobile clinics? Okay, how do we bring care to the people instead of waiting for people to physically walk to us? It is not the same as going to provide, let's say, basic treatment. Why? Because vaccine work is not cheap. We must have inbuilt refrigerators in those mobile units. If the vaccines are not properly handled and the cold chain is broken, they are ineffective, and that is not even in debate. So it becomes a whole lot more expensive than giving TB drugs, than giving HIV drugs. Those do not require anything. Even the CHVs can actually carry them and dispense them. But we cannot do that with vaccines. Mostly they are injectable, which means that you cannot just send, it's not like contraceptive pills where the CHV can go to the village and give the women. Here, you must have skilled healthcare personnel to actually administer these injections. So it is very different. And therefore, what investment goes into ensuring that is going to cost a lot more. So when we look at counties and we talk about county financial allocation, and we expect the county to be the one to now take this vaccine from the county national county referral facility right down to Lokitang or wherever, you know, those places that are hard to reach. Now you have taken that really most difficult aspect and delegated it to the county. Have you financed it? So when we talk about national programs, then they have to look at those aspects, that it's not about the vaccine just being present, healthcare workers being present. How do we get it to the last mile? And in this case, when we say last mile, I mean it literally. Yeah. I will give you an example. When I was a student and I went to E10, which is now, I mean, one of the counties that geographically is most beautiful but most disadvantaged. We would joke that the entire county looks like 3 steps, you know, you're just going sharply across and sharply down and back again. And access even to build roads is a challenge. And one time we had a meeting with the immunization team, and I met this one man, God bless his soul. He would leave his house every Monday morning because there was no electricity at his facility. So he could only get vaccine stock for a week to use the little modified refrigerator to stay safe, which means every Monday he has to restock his supplies. which means on Monday he must close the dispensary because there's nobody else to man it while he's gone. And then he would walk for 6 kilometers. No, he would ride his bike for 6 kilometers and lock it to a tree in someone's compound, because where he had to walk now, there was no road, even for a bicycle. Literally, he was climbing the rock cliff. And he would walk another 3 kilometers upward, now to reach the road, where he would finally take a matatu to the facility, carrying his little trusty little box, pick vaccines for the week, and make this trip back at no extra cost, no incentive, save for his basic salary. Don't forget, the more rural you work, the less your allowances usually are. So the person in Nairobi is getting a house allowance of 20,000, you're being given 5,000, and this is what you have to do. I can assure you he did not do it for the salary. He did it for the love of the children. And we cannot keep running a country on goodwill. What our First Lady here is saying, we want our CHVs out. We want them to find these children. We want to ensure mothers bring them to the clinic. They're not going to function on air. I am very committed to seeing that the President's directive is implemented, that all CHVs will be paid. I like what MOH has said. They have first eliminated the term volunteer. They are not volunteering. They are actually going to be called community health promotion officers. They are going to be facilitated. And I like what they have done to challenge the county, that for what you pay every CHV, the national government will match it. So if you give 5,000, they will give an additional 5,000. If you give 2,000, they will give an additional 2,000. We motivate our CHVs, then we will not have to worry about creation of awareness. Right. That will be done. We will not have to worry about follow-ups. They will know which child has not been vaccinated and do what it takes to ensure this child is vaccinated. Yeah. And when we are doing that, we must look at it wholesomely. Why? Vaccination has perennially provided an opportunity for children to come into contact with healthcare services. Right. So we can now do child monitoring. And that's why we lose our children to child monitoring when vaccines are done. Once we give 9 months measles, we don't see these children unless they're sick. And why is that? Because there's no motivation.
That's the case that Madam Lillian.
Exactly. Yeah. So for as long as they remain on a vaccination program, we not only get them to come to get vaccines, but additionally it becomes an opportunity to provide all other healthcare services that are required by these children that are preventive and promotive for good health. So it's, I mean, we can never go wrong. We know that for every dollar you put into vaccination, you save $54. I do not know any other health intervention that actually can give that much return. It is not a privilege. We must ensure everyone is vaccinated. So irrespective of age, our push towards that you understand now why we are looking at government like this responsibility you take on in a few years is huge. Yeah. We hope you see the entire prongs that go to make this wheel turn. And when you think about budgeting, you're not just thinking about buying vaccines, you're talking about training, we're talking about community interaction, we're talking about strengthening primary healthcare systems. And these are things we need to start doing now, way before we have to think about fully absorbing the responsibility. So keep our eyes open. I am very excited. I have the wonderful First Ladies here to help me keep the government in check.
Madam Lillian, yes.
Nilikuwa nazingatia sana serikali yetu ya Kenya kujitokeza na mambo ya madawa. Kusupply madawa kila hospitali kwa wingi ndio ipate kutoka nje ya ile dispensary ndogo ndogo. Ilikuwa ni ombi tu kwa sababu ile inaleta changamoto hiyo yote ni kutokoza kuwa na dawa. Unakuja hospitali hakuna dawa, wengine wanaambiwa nunua na pengine hana nauli ya kununua. Inakuwa changamoto kubwa sana.
Yeah, I also just wanted to echo what Dr. Nelly is talking about. Actually, it is very exciting to the CHVs, our now community health providers, ours we're calling the CHPs, yeah? they are so excited about that money. And, you know, in Kenya, we are very good in legislation. We are also good in policies. But I have a problem with the governance, because they were already asking me, how sure are we that the government will be paying the right people? So that is a question that is on there. I would ask the government, as they map out these CSVs, can they use a system that will ensure that the right person gets that money, whatever amount it is? I'm already aware the county government of Migori is already going to match what the government is going to give, and in addition, they are going to pay for them NHIF, and they are very excited about that. Something else that I wanted to ask, maybe to find out from the government, there's this program that was brought by the immediate former First Lady, the Beyond Zero. Yeah. I was not a First Lady then, but I've listened to the stories. I've listened to what the effects it had. I've even seen some of them. Can we have a program that can maybe equate or be the same as the Beyond Zero program, such that a van leaves, like now when you're talking about Turkana, yeah, they can get the security that they need, but they're able to drive into an isolated area and they give out these vaccines to those people wherever they will be. Mm-hmm. So I really don't know, because right now you find some of the Beyond Zero vans are down, they are not well maintained because they no longer get that government support. I would really ask the government to bring back that program, even if it is under a new name or under a new procedure, but the benefits it brought to the community is huge. Mm-hmm. Because even for me, when I was doing the cervical cancer vaccines, it is those vehicles that were moving the vaccines around, because you can, those are not items you can just walk around with. Those vehicles were assisting us. So please bring back the Beyond Zero vans and the Beyond Zero program to address the community issues. Mm-hmm. Thank you.
I hope your appeal has been heard loud and clear. We assume the government watches to be able to hear those appeals. Yeah. But Madam Anita, if there's anything you wanted to add before we wrap up.
No, mine, well, most of it has already been discussed, but I think it's important that not just women, you know, because we are focusing our information and advocacy to the women, also the men. I think it's important that we also try and educate the men on the importance of immunization, because you see that the focus is mostly on the women that have gotten the children. So it's important that also the men get to understand that we are trying to build a more resilient population that will be, you know, more productive after immunization, because you realize once you miss the immunization at a certain age, then it becomes very difficult in future to be able to mitigate the problems that come along with that.
No, certainly. And, you know, Dr. Nelly, I'll finish with you. We have a few more minutes. And I was thinking about this whole issue of misinformation. Madam Agnes talked about the whole HPV concern, people thinking their girls will be barren now. It's now Autism Awareness Month as well, and people are thinking, oh, vaccines cause autism as well. So when you're thinking about a lot of the misinformation that is out there, how do you combat that as well?
So we do take huge cognizance of that. Yeah. Because one of the things that, if you look at the KDHS, one of the things that actually was a huge influence on access to vaccines was actually level of education of the mother. And that it was very clear for women who have education at secondary school and above, their children had a vaccination rate of 99%. Okay, so we understand that education has a powerful impact in understanding and acknowledging. But the interesting thing is that now we have seen a new wave where now the highly educated are actually a huge contribution to vaccine resistance, where we have access to internet. And a lot of people will go to the internet as the gold standard for information. Yeah. Yet internet is a free-for-all space where anybody can publish anything that they want, whether it is factual or not. So we still have to go back to basics. How do we talk to people to understand? Science is just that. Science is science. Science does not lie. Okay? And one of the things we have, and if you actually look at even just the history of vaccines, how long it takes to move from conceptualizing a vaccine to even getting justification to take it to trials, to going through the whole period of trials and declaring that this vaccine is safe, is not a walk in the park.
And we saw that during COVID.
Absolutely. Yeah. And you can imagine COVID to us as scientists was miracles because that was hugely accelerated processes. The HPV vaccine, for instance, has been cooking for over 20 years. We are very late in introducing HPV vaccine to our populations. Places like the Nordic countries do not even know about cervical cancer anymore. Their doctors have to come to Africa to see cervical cancer because for the last 27 years, they have already been vaccinating both boys and girls. And so we look at that and we want to have these conversations where we say, look, we need to be very honest about how we share information. We need to be very responsible about how we disseminate our beliefs against actual facts. We saw social media taking serious responsibility during COVID, that all the people who were giving misinformation were actually taken off the platforms. And basically just, we have to be, we have to take it a notch higher and manage misinformation. Because if the people who are looked at as informed and educated will then be the source of misinformation, then can you imagine what's going to happen to her mother in Turkana when that's the only information that is going to get to her? So we do have to take cognizance of that. It is really creating a problem with vaccine hesitancy in populations which we should not be worrying about at this point in time.
Right.
Okay? So moving on, we always imagine that first of all, as a human body, we evolve. And we have lived in this country since 1982, when the Kenya expanded program of immunization was set up. We have raised generations of 40-year-olds who know nothing other than being vaccinated. So when we start to take back these gains, the exposure we are going to give those people who are unvaccinated is huge.
Right.
We always say nobody is safe until the very last person is safe. So we must think about that. And when we talk about misinformation, what every first lady here has said, education, education, education. I was in a meeting with the cabinet secretary recently, and one of the declarations she said is that not only are the CHVs going to be paid, but they also need to be retrained.
Critical.
Exactly. Primarily, the community health promotion officers deal with health promotion. Right. They don't treat. They give information. They follow up and ensure this information has been taken up and has been acted upon. Yeah. So they need to start by being the ones who are correctly informed. We need to understand we live in an era where you will not just tell people do this and they do. You need to explain the why, the how it works, why this is important, because you are empowering them to actually take that decision individually. Patient-centered care, community-centered care, family-centered care, that's the mantra. And if we get it right, we'll get information right, we'll get our outcomes correct.
And that's what this conversation is all about. I want to thank our distinguished panel of First Ladies for coming in. Thank you so much for sharing your insights from the county. And we hope that the change actually begins to be seen from the village all the way to the city. And thank you so much as well, Dr. Nelly, for coming in and demystifying a lot of the myths. Those WhatsApp groups can be very dangerous in terms of information, but keep the conversations going wherever you are watching this from. It's critical that the right information gets into the hands of those who need it. Thank you for watching. I'm Victoria Rubediri.